Today on The Future of Everything, the future of allergies. I'm going to start with a little bit of a personal story here today, a little unusual for me. I grew up in New York, and we spent lots of time out on Long Island, a little town called East Quogue, where there was abundant seafood. Clams, mussels, lobsters, shrimp, crab, and I have extremely fond memories of my grandfather buying lobsters for everyone. We would put newspaper on the table, get bowls of butter melted, and dip lobster and dip seafood in the butter and eat it. It was wonderful. And we had shrimp around the house all the time, and my mother loved it and cooked it, and I just loved seafood. When I was 24 years old or so, I was traveling. I was on a trip to Boston, and I went out to dinner to some seafood restaurant. And I returned to my hotel, and I had a runny nose, I had watery eyes, my face was obviously red, and I was wheezing. I had asthma. I was having trouble breathing. I didn't feel like I needed to go to the hospital, but this was a big enough deal that when I thought about it, I said, you know what? The last couple of times when I've been to seafood restaurants, I've had this kind of reaction, and now this is obvious. I need to be evaluated. So I went to the doctor, and they sent me for allergy tests. And back then, maybe now too, they had me lay down on my stomach, and in 60 different spots on my back, they poked me with a little needle and put in a little challenge, like a little bit of leaves from different trees and extracts from different animals. And they did 60 of these, and at the end they said, well, we did 60 different food and plant and other challenges, and you had a reaction to 58 of them, including big reactions to shrimp, crab, and lobster. And in fact, the only two things you didn't react to were horses and rabbits. And they said to me, have you ever been anywhere near a horse or a rabbit? And I said, no, I'm from New York. I don't know what rabbits look like. I don't know what horses look like. And they said, yeah, so if you ever do come in contact with them, you probably will be allergic eventually, but you've never seen them before, so you're not. So they said, no more shrimp, crab, or lobster. In fact, clams, mussels, oysters were okay, but those other three were not. And I was profoundly sad. And for the next 30 years, I stayed away from those foods. It became actually part of my self-image because I always had to fill this out. You know, when you go to a meal, they say, do you have any food limitations? And I always listed it. It really becomes part of my self-identity. And then I met Dr. Kari Nadeau, who we'll be speaking with in a moment. But first, I want to finish my story. And I described this. I said, oh, you're an allergy person. Let me tell you about my allergy because it's bummed. And I used to say what I might do is have my final meal. I'll be old. I'll have some terrible disease. I will just have a big plate of lobster and that'll be it. That was kind of what I was thinking. And Kari said, no, I may be able to help. And then we'll make this story shorter and we maybe talk about it more later. But over the next 6 months, she treated me in a certain way with certain new medications that we can talk about. But the bottom line is that over that 6-month period, I was desensitized and I was able to take my first shrimp and then my first crab and then my first lobster in more than 30 years. And actually, there was an emotional aspect to this because I was able to eat these foods that I had eaten with my grandfather and with my family as a young boy. It was a big deal. And in fact, there's been 2 or 3 years since then, and I've had paella, the famous Spanish dish filled with seafood. I've had that on my birthday every time now since then, and I'm pretty sure that for the rest of my life I'm going to be having paella on my birthday as a celebration. And in fact, I like to believe that I was instructed to make sure that I ate a certain amount of crab, shrimp, and lobster on a regular basis. And I have never been so happy to obey a doctor's order than to tell my friends, I'm sorry, but I simply must have lobster this week because it's doctor's orders. Okay, so that's my story. Now, Dr. Kari Nadeau is a professor of pediatric food allergy, immunology, and asthma at Stanford University. She is an expert on food allergies, their prevention, obviously their treatment, and the ways in which climate change may be impacting both the food supply and the allergies that result from it. Let's start out with basics, Kari. What is a food allergy, and are they increasing in the population?
Yeah, thanks for asking that. And thank you for inviting me here today. It's really wonderful.
It's our pleasure.
It's great to hear your story and make sure that we can deliver on hope and promise and make sure people get to eat lots of lobster in the future without fear.
Because of that story, I would take a bullet for you.
Well, it's a team approach for sure. And there's lots of science behind what you were able to do. And it's really all you, Russ. And I appreciate the fact that you can talk about that today. So what is a food allergy? We like to describe that as a disease. It's a disabling disease, as you suffered from. It's a disease in which you have to eat a food, and when you do, you have these reactions like you did. You have itchy eyes, itchy nose, congestion, you can wheeze with it, you get a lot of mucus, and this can all happen within 6 minutes.
Yes.
And in fact, 80% of the time, you mostly have just hives and skin, but about 20% of the time, you can have abdominal pain, vomiting, as well as blood pressure changes, and then wheezing. So we take it really seriously.
And that was part of what they warned me about and why I needed to stop, because I had this increasingly brisk response, and they were worried that the next one could be a big bad one.
Exactly. So that at any point in time, someone that has a doctor's diagnosis of food allergy has a 25% chance of having a severe reaction. So, and that the typical food allergy patient, about 60% of their reactions at some point in their life will be severe. So it accumulates as you move forward in life. So I'm really glad that you didn't have to suffer, but importantly that we took care of you with therapy that we need to make sure lasts. But contrast food allergy to food sensitivity.
Okay, good. So that's another thing that's in the air, a lot of discussion on social media.
Exactly. And so we like to differentiate food sensitivity versus food allergy because with food allergy, we know that that's a molecule called IgE. I call that the match that lights the fire behind allergies, and specifically food allergies. It can be quite dangerous. It's not the only molecule that we like to look at in food allergy, but that's the molecule that we know if you have a food allergy, that's going to be positive, and we need to watch that because any amount of dose can affect you. You might say, well, last night I ate a whole pot of lobster, but in fact, another night you could actually eat just a small amount and have the same similar reaction.
And this is called IgE. It's an immunoglobulin, I believe.
Exactly.
And it's type E.
That's right. It's type E. It's one of the lowest frequent immunoglobulins in our body, but we think it was meant to probably fight against parasites, not meant to fight against food, but it has this maldirected in some patients, this maldirected attack on foods and also pollens and other allergies that people can have. 1/3 of the whole planet has allergies, and about 8 to 10% of people have food allergies. So we need to think about how much this IgE does its damage, and it is serious. The food sensitivities don't have IgE.
Okay.
And food sensitivities are, for example, when you bite into an onion and you start to cry, or you bite into something and it starts to giving you bloating, like milk with bloating.
Yes.
Or you eat something and it gives you a headache, like
Yes.
some people have that with migraines. Those are food sensitivities. Those are not allergies. No one can anaphylaxis and have a near fatal or fatal reaction to those.
And we're not saying that this is in their head. This is a real physical reaction, but
Absolutely.
It's not mediated by this IgE molecule. It has other mechanisms.
Exactly. And what we're learning is there is a strong mind-body connection. And so what we're understanding now is people that have certain taste receptors and certain abilities to know that the food bothers them, they should avoid those foods. Your body's telling you not to eat those foods.
This is the future of everything. I'm Russ Altman. I'm speaking with Dr. Kari Nadeau about allergies, both allergies and food sensitivity. So you said food sensitivity has these other mechanisms, perhaps related to taste. And are they all coming to you, or do you send certain groups away and welcome other groups to your practice? How do you think about all of these as a physician?
Yeah, I think as a physician as well as a scientist, when you think about trying to discern those items that are associated with allergy, you always need to understand what's the other and test what we call the null hypothesis, right? Mm-hmm. And be able to understand these discriminatory features between who really has an allergy and who doesn't, and how do we help the sensitivities as well? And are those perhaps related to immunology but in a different pathway? So what we've been doing is taking all comers, and we really want to also have people that don't have any allergies or sensitivities, because we also need people that have no
what's different?
Disease
there
or what we call
difference.
Controls. And then I do see patients in clinic with all of the above. Mm-hmm. I like to take care of families from kids to pregnant moms all the way to people that are 100 years old. I think it's important to relay our knowledge and help families and all ages, because all ages have food sensitivities and food allergies. What we're very careful about is with celiac disease, for example.
Big
That's
issue.
an inflammatory disorder that's very different from a food allergy, but that relates to a different arm of the immune system. And those people can have chronic conditions, but that's more related to diarrhea and other issues. And those people I would refer to GI specialists, because that's their specialty.
So let's just take a moment on that, because as I understand it, gluten is one of the big problems with celiac disease, but gluten has had a bad decade. And so can you talk to me from your perspective about what is a reasonable thing to say about gluten as a cause of celiac disease, and then gluten, I guess maybe we would say sensitivity. How do you think about that, and what's the advice to people who are worried about this?
Yeah, it's really fascinating. I think that in all of our society and all around the globe, we've been looking at gluten. And gluten is a protein. It's in wheat. It's one of 33 different wheat proteins that are in existence now. And when we evolved with the wheat plant. But now the wheat plant's kind of different. And so our gut necessarily, for some people, when it eats a lot of gluten, it has an inflammatory reaction to it.
Wow.
Now, for other people, they don't. And so it's important to know whether or not you really have a gluten sensitivity or you don't, and that's where you need to talk to your doctor, because you shouldn't just avoid gluten. There's a lot of great things about gluten products like fibers that really help you.
It makes my bagels that I make every Sunday extremely chewy.
Exactly.
And so I always worry about, because I'm adding gluten back into the, it's wheat plus extra gluten, and then people say, oh, Russ, it's so chewy. And I'm like, yeah, there's a secret ingredient.
Yes,
there.
right. And gluten is this wonderful protein that we evolve with. And so for people that think they have a gluten sensitivity, go check it out with your doctor first. Now, for people with celiac disease, it's a maladaptive response to one of the specific peptides in the gluten molecule that actually then creates the celiac disease. But that's mostly genetically predisposed.
And that's not what we're calling an IgE mediated. So
Right.
let's go back. So I love this. I mean, we will talk about this, but it took me probably 5 to 10 meals to put together that this food eating was causing problems. And I really only knew seafood. I didn't know what it was going to be when I went to. So tell me about the detective work that you have to do in figuring out what is causing these reactions.
That's right. I think like what you went through with all those pricks in your back, that seems rather draconian. And we still use those metal pricks, for example.
I was wondering about that.
And you think, well, why are you doing something that's been in existence for 100 years? Well, right now it's the best that we have. And so we take the scan and we can infer from the scan what your body might do inside. But it really is only skin deep, because you have these little cells called mast cells that stay in the skin. They don't go into your blood, and they can last up to 9 years in your skin. And basically, when you prick your skin with that specific protein or allergen, then your mast cell will pick it up and then have a reaction to it via IgE. And so
it's actually a very relevant test.
It's very relevant. It's relevant also for the physician and very practical, because you can do it within 10 minutes in the office. And so that's nice. And if you have the right person doing it, it's very standardized. So we do that in our clinical research at Stanford, as well as many other people use it as a tool. When it's negative, it's 99.9% negative.
Wow. So if I didn't get any swelling, then they say, Russ, maybe it's time to go see your therapist. So let me ask, those 60, are they the most common allergens that you see empirically? Like, we have enough experience to know hay fever, shrimp, whatever. I felt lucky that the things I was worried about were listed on the list of 60. So who comes up with the big, let's call it the big 60?
Right. So what doctors usually do is you come into their office and they try to decide, okay, what are you allergic to? And they try to get that from your clinical history, and then they design their skin test accordingly. But importantly is when you don't know, like you didn't know, and like you're saying, you bite into a meal and you're confused because maybe you could have eaten those foods previously, but now all of a sudden you have a reaction. And for adults with food allergies, that's 50% of adults with food allergies now. We just published a big paper showing that for people, 10% of adults in the U.S. now, and probably around the globe, has food allergy, and they don't know about it until they're an adult. Now, about 300,000 kids in California, for example, learn that they have food allergies for the first time when they're at school.
Yeah.
So eating foods and understanding that, we're trying to get better at prediction. So right now, with Stanford and many other institutions around the world, we are getting it better at prediction. We shouldn't have to do skin tests forever. So we're looking at blood markers to be able to understand, even before someone develops an allergy, what they might develop it to.
Yes, and it sounds like you also know that there are genetic familial connections. This is the future of everything. I'm Russ Altman. I'm speaking with Kari Nadeau about allergies. And you mentioned kids, and tell me about prevention. I know new moms are getting a lot of information different from even what we got when our kids were little, and presumably it's based in science. What is the current advice? What is our ability to prevent allergies looking like these days?
I think over the past 5 years around the globe, there have been a lot of randomized clinical trials now, and we actually have the knowledge to be able to think about how to prevent, which is fantastic.
Yes.
When I was doing this and when I had allergies when I was growing up, no one was talking about prevention. Everyone was talking about therapy.
Right.
So we need to predict, and then we need to prevent. And so with prevention, what's known now for preventing food allergies is, I call it sort of the Ds. Dry skin. Try to avoid dry skin. Avoid detergents when you're an infant. Make sure that you use good creams, good emollients to protect any type of dry skin. Because through dry skin, allergens in the air, and there are many, can actually touch the skin, and then the skin reacts in a maladaptive way and then creates allergies inside your blood.
Okay.
So we now think that the mantra is, through the skin, allergies begin. Through the diet, allergies can stay quiet. So the next D is diversification of the diet. So if you eat a lot of diverse proteins early and often when you're an infant, we think that that will also tolerize the gut and protect you against food allergies as you get older in life.
This is what I've seen. I am pleased to have an 11-month-old grandson, and my daughter is spectacularly disciplined in the introduction of foods in a serial, thoughtful way that makes my wife and I blush, because it was like, well, here you go, eat this, see how it goes. But she feels like she's really gotten good information from her pediatrician about when and how strawberries, peanut butter, all of these things that we know can be associated with allergies.
Right. And so it used to be thought in 2000, and guidelines throughout the world were made where people were in a very sort of precautionary reflex. And I think they meant well, because there was this epidemic increasing of food allergy. They suggested, delay the introduction of peanuts, shrimp, eggs. But in fact, in those countries that actually took up the guidelines, they had the highest rates of food allergy.
So
and
the avoidance
actually created a higher degree of epidemic. Those countries saw a doubling of tree nut allergies, for example, every 10 years. So with that, now they've thought about the data. Randomized clinical trials occurred over the past 5 years. So now we're saying diversify the diet early and often. We're also saying have some good dirt. Eat some good probiotics.
The third D?
The third D is eat some good dirt.
Oh,
Not
I
bad.
love that.
So make sure that you have good fiber in your diet. We have a great group of people here at Stanford around the world looking at microbiota and how that's going to help tolerize our gut better, to understand that our gut shouldn't be having this maladaptive response to foods.
The 3 Ds. This is the future of everything. I'm Russ Altman. More with Dr. Kari Nadeau about allergies and sensitivities next on SiriusXM Insight 121. Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Kari Nadeau about allergies. And one of the interesting things that you've written about and looked into on the research side is the impacts of climate change. So of all things that I thought we would be talking about with allergies, I wasn't expecting climate change. So can you link for me how climate change impacts your life as an allergist? Absolutely.
So with climate change, and that means that we are seeing this 1.5 degree centigrade increase in the overall, and that's due to the carbon dioxide emissions. And with that, that carbon dioxide and all of the particulate matter that are associated with that because of diesel exhaust emissions, that really affects people's asthma. So there's plenty of studies to show that that small little matter that you can kind of see in the air when you see that polluted day, and that's about what we could say 2.5 microns. That's really small, but it gets into the bottom of our lungs and it creates terrible havoc. Our lungs don't like that.
I grew up in New York in the 60s, and I remember in a skyscraper, and I remember looking at the skyline and seeing a little brown layer halfway up the Empire State Building pretty much every morning, which I was breathing. Exactly.
That brown layer is getting into our lungs, and in countries like India and New Delhi, it's really more of like a black layer. And so we need to be careful about what climate change is doing, and how what I see in my clinic, for example, is on bad air quality days, I'll see more asthma in my clinic. In the emergency rooms, the increased fold of asthma ER visits is about 4-fold. But then take that up 10 times when we have wildfires.
Yes.
So we're also seeing California, but all around the globe. In Kenya, they had wildfires. We're seeing reforestation issues in the Amazon. All the time that fires are used, that's very similar to this particulate matter, but it's 10 times higher in the
Right.
sky. And so you see people, even that don't have asthma, come in with wheezing. And we don't know to the degree by which those types of climate change factors, those extreme weather conditions, even after 5 days, are increasing people's visits to the emergency room due to stroke, due to heart attacks. So we see all this
So
increase.
ripple effects, really,
Big
of this
ripple
air
effect.
quality. Now, so the connection to asthma really makes perfect sense. Does any of the climate change actually impact on the food and food allergies, or is that a different thing?
Right. So the one thing about climate change is, of course, what people are seeing throughout the world is that there's more drought or there's more flooding, and that affects our crops. But in addition, because of the fact that we're having to reuse water supply and we don't necessarily rotate our crops like we used to in the past because of the fact that water is such a commodity now, we have less nutrients in our given foods. When we were growing up, there was a certain amount of zinc, a certain amount of calcium in spinach. Now that's being depleted, and so the typical spinach plant has much less zinc and calcium in it, for example.
So spinach ain't what it used to be.
No, exactly. Popeye would be sad.
And then that's easy then to decide, to imagine that when that molecular makeup of the food switches, that it might change allergy propensities in one direction or another.
That's right. That's the next big question, is whether or not, because we're having to use waters that might have a slightly higher amount of detergents because they're having to be used again, those detergents, even in 1 parts per billion, for example, can change how proteins are folded. And so that affects, when we eat the food, how those proteins are being digested. So all these things are showing up in our immune systems, in the way that we process foods, in the way that we see foods as people. So we need to really follow this carefully, as well as look to what degree climate change can be improved. Because we do see that, for example, when filters were used in school buses, or when we take away ozone issues, or, for example, fluorocarbons in the air, we see improvements in asthma. We see improvements in allergy. So we know that.
That's great. So the game is not lost.
Help.
We haven't lost the game yet.
Absolutely.
Now, I do want to move on to cures, because this is one thing that your lab has become famous for, and of course I'm personally grateful. Tell me what is the current landscape for curing allergies if we are for some reason unsuccessful in preventing them, which of course will happen.
Yeah, I think we always have to have that moonshot as scientists to try to create a cure, because in the goal of creating the cure, we can actually mitigate it along the way. Right. And that maybe it's not everyone that we can cure. And when I say cure, I mean that I'd like to make sure that when you get to be 100 and over, that you can still eat your lobster without a problem.
Paella
Exactly.
for my 100th birthday.
There you go. That's the goal. And so with that goal, we want to make sure that every person that comes into our clinical research unit, as well as clinics, we understand what their goals are, and then we can make sure that we can face forward. So a lot of people say, well, I'd like to eat my food and not have to worry about accidental ingestion. Or they can be like you and say, well, I'd actually like to eat that food, not just worry about accidental ingestion. In large amounts.
Not just trace contamination. I'm talking 2 lobsters.
Exactly. We had one college student who was very allergic to milk. I mean, put a little milk droplet on his skin and he had a horrible reaction. He wanted to eat a whole pizza. And so that was his goal. So we used the very same method that we used for you.
Good. So let's get into it.
What we did was to say, okay, we know that the body, and this has been going on for hundreds of years, if we feed back the body every day the very same thing that they're allergic to, and this has been going on for pollens, for insect allergies, but what about food? What if we feed you back very small amounts and increase those amounts slowly over time? We train your immune system, just kind of like how we train for races and build our immune system. It's like building muscles. And so with that, we build up your immune muscles, and over time, you adjust and you become desensitized yourself. It's the beauty of your own immune system, where you readjust and decrease your own allergies to that food. But along the way, you can have reactions. Right. And that's the hard part. 30% of the people, while they're doing this type of therapy, can have bad abdominal pain or bad wheezing, and that's scary.
Or the reaction that led them to come to the doctor in the first place.
Exactly. So it seems rather paradoxical that the treatment is actually causing more frequent reactions than what that you're trying to avoid in the end. And over time, when you get done with this, your reactions decrease and decrease. However, what we decided to do was people that have more than just one food allergy, and many do, about 70% of people now have more than one food allergy. And so with that, we said we want to treat all ages. We want to help be able to treat multi as well as mono allergies, and we want to do it safely. And so at the current time, there was a drug that was being used in asthma that had been made by Genentech and a prior company called Tanox, and that was called anti-IgE. And so it basically
Which is a
quenched.
good sign because you said IgE was the problem, so anti-IgE is sounding good.
Exactly. So it quenched that match that lights the fire. But it's not perfect. And so what happens is we use the anti-IgE as a sort of a cover with that increase in the food at the same time, which is what we did for you.
And I remember this, yes. So you gave me these injections before you ever had me eat anything. I came back a couple of times, and you said, Russ, we're pretty much wiping out your IgE.
We're building it up, and then we start feeding that food to you so that it's done under that cover, that blanket of a protective device.
And that drastically reduces the chance that I'm going to get the bad reaction even on my first little tiny bite of shrimp in 30 years.
That's right.
Which is what happened. You guys were all around me. They had the crash cart. It was very memorable. Like, what did the crash cart hear us? Well, we think this is going to work, but we're not 100% sure. And so then I took my little first bite of shrimp in 30 years. Everybody watched me. Nothing happened. But you did make me stay there for 6 hours to make sure nothing happened.
Because we're super conservative. We always like to be careful. And for all of the people that we've treated with this particular regimen, we call it Zola or anti-IgE with the food. We've never had any severe or bad reactions, but we always like to be careful.
Of course.
And with that, we can also increase the dose of your food so that you can get done in 6 months, in 9 months. Usually it takes about 5 years if you don't use Zola.
I believe that when you had me do the shrimp, I had a little tiny bite, but in that same session, I think I ate 2 full shrimp. And so there was an acceleration.
Exactly. And we want to do that because that helps people.
This is the future of everything. I'm Russ Altman with Dr. Kari Nadeau. We're speaking about allergies and the cures. So is that going to be the way to cure, or are other modalities also arising?
Yeah, I think one thing in science is that we always need to think about improving, and that when you look at your data, you always need to kind of look at the data on the edges and say, well, who's doing really well and who might not be doing well at all, and why is that? Not everyone fits into the Gaussian distribution of data. So with that, we've been looking on the edges. We've been looking at how to improve, and so this is very cool. So now a gene therapy has been made. So for people that don't even want to eat the food because it's quite anxiety-provoking, we now have a plasmid that we insert under people's skin so the person can become their own peanut plant, as it were. So they start making their own peanut protein in very small amounts in a very measured way daily. You can't do this every week, for example.
So instead of eating the shrimp, there's something in my body that's basically secreting shrimp-like compounds so that I can slowly become used to it.
And it's really neat. That is, to me, this precision medicine where you're taking science, you're being able to capture that, use it to effectively help someone and enable them to be desensitized to X, Y, or Z. So gene therapy, I think, is something very exciting. And then I think there's other cures that we're looking into now that use other biologics that might be safer and that might treat a lot of different ages. So I'm excited about the future. We're running about 27 different clinical trials throughout the world in food allergy now.
So unbelievably good news for those of us with allergies. Thank you for listening to The Future of Everything. I'm Russ Altman. If you missed any of this episode, listen anytime, on demand, with the SiriusXM app.